This again. I have made multiple recordings and none of them seem to be working. And I think every time I go to do another lecture, they're getting shorter because I'm running out of patience. Anyways, fingers crossed that all of this goes through and saves. So this week, we're going to continue talking about discrimination and bias based on weight size. This presentation was made using data from the World Health Organization, presented to physicians, presented to doctors, and I think it's a really important concept that I'm trying to get at as we learn in our curriculum as exercise physiologists. So the goal of this is to go over what is weight bias, and we've already done a little bit of this in the last couple of weeks. What are the theories behind it? What are some of the terms that are used? The prevalence, the implications for taking care of someone, and kind of strategies we hope that might end up changing. So there's been a lot of research that's been done on implicit bias, which is what are your thoughts? And if you've ever done an implicit bias test, which I think I have later in the semester of us trying to do, think about these two images you see on the screen in front of you and these words, and notice which image you're more tended to place the word with. Marathon runner, organized, someone who knits, someone who eats junk food, someone who enjoys canoeing, someone who would be a good leader, someone who's socially awkward. Did you notice? Could you admit to noticing that there's a tendency between the two different body shapes? This is where a lot of research has begun on what we call implicit bias. And from this, researchers have begun to have some more robust definitions. Weight bias, negative attitudes towards, beliefs about others based on their weight, right? Their body size. Obesity stigma is a social sign or social labeling that's someone who's a victim of being prejudiced or discriminated upon. That's what we call obesity stigma. Weight-based discrimination is the actual action where someone has, actually had behaviors happens based on, again, either the weight or the bias or the stigma. So bias, stigma, and discrimination, as you see, they're very interconnected. And defining weight bias are attitudes and beliefs, a lot of negativity, beliefs, attitudes about obesity and people with obesity. Obesity stigma is labeling and stereotyping, deeply rooted. We find, most research finds that obesity stigma happens at a very young age. You see it in elementary school. Classic situation is an elementary phys ed class that allows kids to pick teams, or you get to pick who you want on your team. And commonly what kids learn at a very young age, and it's felt, and it's, you probably can relate to feeling this and having memories of this, of who is often the last child picked for a team, right? That labeling that happens with the obese, chubby child is commonly the one who gets picked last for a team. Not always, but common. Weight-based discrimination is, again, the actual action, so whether it be verbal or physical, it could be very subtle, it could be work-related, it could be within families. So very similar but different definitions. Words that come out of the research is awkward, lazy, sloppy, non-compliant, unsuccessful, lacking self-discipline. All of these, all of these types of words seem to be commonly kind of surfaced through research that's been done on negative views of obesity. When we think about population health, lots of stigmatized conditions that affect large portions. They are very persistent. So studies have looked at housing, right? So who's getting housing, employment, looking at base salary and income, promotions within a workforce, social relationships, who weds, who doesn't, wed, and psychological and behavioral problems, and looking at mental health issues, access to health care. When you talk about population health, this one thing called obesity, right? It's a disease. The stigma behind it has so many layers of complexity. So stigma is really a burden that affects people above and beyond all of these other health issues they have from having obesity is very, very complex. So the consequences of the person with obesity is shame, guilt, anxiety, depression, poor self-esteem, body dissatisfaction. Many of these end up leading to negative health outcomes. So they end up learning more negative behaviors, which seems so backwards, right? A lot of healthy people think, well, if this is what's happening, then do the reverse, and it just doesn't work like that. Anyways, weight bias also negatively affects access for treatment. We see a lot of obese people with education, how long they stay in school, how much they help the self-efficacy to exert in education. Employment opportunities are less, quality of healthcare is less, feeling inadequate, unable to be comfortable in a healthcare setting, unable to open up to physicians, following up on appointments. So the stigma does become what we call a population health problem. Now, in this class, we're talking about one thing: exercise. What is your role as a strength and conditioning or an exercise physiologist, or whatever your title is going to be? What is your role going to be? But I want you to realize that this stigma is deep, and for somebody like ourselves that would have direct one-on-one interaction with someone who's obese, we do have the ability to be very positively impactful. I want you to realize that stereotypes damage people's identity. It suppresses their individualism. They end up with a lot of stress, mental health issues, social exclusion, discrimination, loneliness, very difficult time following through on goals, whether it's nutrition or education or fitness. So it definitely leads to the burden of social economic health consequences. The question I have for us in this class, and we're going to do this again, move on next week into doing an activity about yourself, is who has bias? We all have bias. It's how much we have been exposed. There, again, studies of young children as young as 3 years old, have a tendency to state comments about body size that's learned within their family, within their environment. Pre-adolescents, parents and families, healthcare professionals, teachers, students, nursing students, medical students, right? Any levels of teacher training. Individuals themselves with obesity have obesity bias as well. Within the workforce, who we see getting promoted, who we see with higher, salaries. It is so systemic, very prevalent, and something that is a little bit of a taboo thing. Like any form of discrimination, it's an awkward thing to think about. We all want to think we're perfect, and we're not, right? We know that there is this privileged way of thinking that it's rooted when, as we age, as we are become the person who you are. These beliefs start early on, right? The common belief is that obese people eat too much and exercise too little, right? That's basic calorie in, calorie out is just this tilted problem. So we think it's simple, it's not. There's also this societal desirability to be thin within our Western culture. We see it on TV commercials, we see apps on your phone to make yourself look prettier and slimmer, and this pressure, and leading to what is known as a social theory, social identity theory, which is what begins to cause weight bias, feeling inadequate, putting blame on others, really dysfunctional thinking. So we ask the question, do you think health professionals have weight bias? And of course we do, right? So some of the big studies have been done on nurses, been done on physicians, have been done on students, been done on teachers. So the public health message is that then the question is, do our messages, our public health education, public health strategies contribute to weight bias? Yes, that is the other answer, right? It sounds so simple, just eat less and exercise more. So what the research has been done, so all of these slides have been created based on research, and the big studies have been done on dietitians and nurses. The studies say that they view obesity as overeaters, lack self-control, have no willpower, are unattractive, are insecure, move slow or non-compliant, overindulgent, lazy, unsuccessful, blah, 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 right? Nurses have stated in some of the research studies that they themselves prefer not to care for patients that are obese. They feel repulsed by them, would prefer not to touch them. Psychologists have pathology behind these severe symptoms and negative attitudes and worsening prognosis. I will tell you myself, with my work in bariatrics, especially with a psychologist, when I do a tandem, a joint appointment, so myself and the psychologist, incredible amount of underlying mental health that's caused by this negativity about their body size that becomes learned and kind of permeates in them, that is heavy and difficult for them to follow through on goals. Within medical students, the research states that medical students have been, in studies, state poor self-control, less likely to adhere to a plan, sloppy, awkward, unsuccessful, unpleasant, similar to other studies. Physicians themselves have equated to the implicit bias as non-compliant, lazy, lacking in self-control, weak-willed, unsuccessful, unintelligent, dishonest. These are physicians, right? So no one is perfect, and we need to understand our implicit bias. We need to understand our overt feelings we have, and we need to find ways to help this. So we know that the impact on quality of care is definitely a problem. So the ambivalence about treatment roles, less time is being spent with obese patients, less time discussing and engaging with them, lots of negative symptoms are, what's happening, preventative medicine is not happening. We see higher risk among obesity, not just because of the fat that they carry, but also because of the lack of education, a lack of preventative services they've been screened with, very few interventions. So we have this barrier we've now created. Then within just the physical surroundings, inaccessible equipment and facilities, patients are embarrassed about being weighed. They already know they're overweight, so getting on the scale is more humiliating to them. Receiving unsolicited advice about losing weight all the time, even though they have heard it, they know it, it's just not working. Receiving inappropriate comments about their weight, being treated disrespectfully because of their weight. So these are all barriers that happen within the healthcare setting. The training on obesity is where it's lacking, which is why I keep pushing some of these things for you to reflect on. Because if at the end of this semester, our little weekly activities we do together, if one thing helps you to be more inclusive as a person, more accepting of all, and being able to help connect with someone who I know you all have the tools to do with, I did my job. So weight is a conversation stopper, right? Professionals who don't know how to engage in a conversation, which is most, it becomes what we call stoppers. So professionals who have reported they don't know how to approach, they don't know what words they should be avoiding, they don't know how to make conversations unawkward. So it means that we need to shift our curricula, right, our classes that we give to training people to become healthcare providers. Lack of training, lack of health promotion, nutrition and lifestyle contributors of how do you put someone who's obese on the right diet program, right? Because just telling someone to eat less and exercise more isn't effective. It's not effective. And I'll tell you, from people who are so overweight they can barely walk, we still need to find something for them to do. So the training in weight bias is really not included in a systematic way through all layers of education. And that is really what we need. We need more education about obesity bias. Patients state, these are some quotes directly from an obese patient, right? So the perspective is simply eat less, move more, right? So quote from the obesity perspective, when I deconstruct this message, it says to me that public health professionals believe that I did this to myself. So they don't need me to help find evidence-based treatments. I'm sorry, I read that quote wrong. Another quote is, the eat less, move more message makes it sound really simple, but it isn't. But my journey has not been simple. It has been difficult for me. Every day is difficult. Someone else says, I've lost over 100 pounds, but I'm still obese. According to BMI categories, my goal is to maintain the weight loss. Based on what I'm doing now, I cannot eat less and I cannot exercise more. So I will never be able to achieve healthy weight range promoted through these public health campaigns. I'm at my best weight and I need to accept that. So what these quotes are telling us is patients feel frustrated, lack of effective weight management, they feel trapped in these yo-yo diets, that obesity prevention does not represent their realities because they have obesity, so prevention's not helping them. Public health message puts blame on the individual, it's not giving them tools to use. They feel shame and blame for not being able to implement the recommendations that we are telling them to do. So we believe that the bottom line here is these messages are simplistic and narrowly focused. They're ignoring the struggle that people have every day. The underlying assumption is that weight management is easy. It's assumed that people with obesity are bad people and that they're irresponsible. Untrue. Stereotypical images, the idea that people with obesity engage in unhealthy behaviors and make unhealthy choices, right? Not always true. There's resistance and rejection to the public health message among obesity. So patients' perspective is this internalized stigma that develop unhealthy coping strategies, unhealthy eating behaviors, binge eating, unhealthy weight loss practices. This happens at a young age. So they've been in a family, in an environment, a school, all of their social settings, and these coping strategies begin happening. And the binge eating and the relationship with food versus people ends up becoming very complicated. And if you're of yourself, ideal height and weight, and it's something you've never struggled with, it's very hard for someone who's never struggled with obesity to be able to have that empathy and that connection with, wow, this is difficult. This is not an easy thing to overcome. So delay preventative health care, adopt poor self-care practices, avoid interactions with healthcare professionals. These are all things that happen among someone who's obese, right? So they're not getting help when they need to. They don't usually comply with health appointments with physicians and counseling. They avoid meeting up with healthcare professionals. They are at high risk for mental health, poor quality of life. So, I'm sorry, you blocked off some of this, but the summary between the two. So the individual consequences of the obesity is unhealthy eating and low physical activity begin at a very young age, and then it just seems to continue. Psychological disorders, and then this weight stigma usually happens with what we call stress-induced pathophysiology, right? So now they definitely have been exposed to negativity, they have extra stress, they have the pathophysiology behind them. Substandard health care, when they end up reaching out for help, they're not getting what they need to have. From the health perspective, disregard of societal and environmental contributions, so most healthcare providers, our system is unable to realize that it's more than just the person eating the food. It's some of the things we've talked about in our discussion groups. Impaired obesity prevention effort. We see higher risk for chronic illnesses, morbidity, mortality, health disparities, and a lot of social inequalities happen among obesity. A lot of things that I'm saying resonate with a lot of discrimination factors. If we're looking at gender discrimination or race and cultural discrimination, this is a very common conversation with all of these inequities. And now we're taking a look at something that is a common theme through all nationalities, all genders, right, is this ability of someone to have an obese body size and just how systemic this is. So looking at some of the research, again, interventions addressing weight bias, not a lot of studies. Have few studies, 17, mixed samples around 15 students in training, 2 that are looking at healthcare. There's really no magic way to address weight bias. Deciphering successful strategies and approaches really requires lots of interventions. Need to move beyond awareness. We are now aware of it. I'm making you aware of it. And now we need to actually go into having some competencies that we can put to action. So we can change these young children that are going to one day be yourself at 20, 30 years old. This has already been addressed. So within the healthcare sector, the message is presenting facts about uncontrollable versus non-modifiable causes, right? There's some that you can and some that you cannot control. Evoking empathy, positive contact. How can you relate? How can you connect? How can you be a facilitator and an ally to help people get to their goals? Peer modeling, shadowing with empathetic experts, and if you know people in healthcare that are very good at being empathetic, is what I want you to practice on yourself. Repeated exposure to patients over the long haul is going to help you. Consider unintended consequences, a population health message. This is very critical reflection, is think about the unintended consequences we hear from some of the messaging that is being sent. If we're aiming at healthy eating strategies and the message to the entire population is just eat healthy without focusing on weight reduction. I just want you to eat healthy to be healthy, to feel good about yourself, not about what you weigh on the scale. It's not about what size your pants are. It's not about focusing on dropping weight. Challenge healthy weight messaging by shifting the focus to health and moving away from quantifying. I am definitely the person who says, I don't want to weigh my obese clients. I'm not going to ask them for how much they weigh, right? I'm not going to. I want to ask them, how do you feel? Every day I train them, how do you feel? Tell me how you feel. I don't care how you weigh. Don't weigh yourself. Once we start getting weeks and weeks of feeling good, guess what? The scale is going to begin changing. So really taking that stress off of the quantifying number. Challenge individual choice and energy in and energy out paradigm. So yeah, we understand that that is the true calculation, but we really want to challenge them to understand what pieces and parts are easy for you, what do you struggle with, what are small steps that we can take in trying to, set a goal that we can stick with. And examine the language and the beliefs, the values, the practices, all of these things that can help change some of the inequalities we have in health. So our recommendations are to consider the complexity of people's lives and experiences, all of the things they've been through. Many times we just don't. You just see them for their size. And many times you're just frustrated that they just keep eating junk, not realizing that maybe they've never been taught in the kitchen how to eat. They've never been taught how to read a label. They've never been taught basic food and basic portion sizes. It takes a long time to untrain those bad habits. Give people with obesity a voice. Engage them. Talk with them. Setting goals. Engaging public health strategies. Again, shift from individual behavior change to improving our culture. Right? I want you, all of you in this class, to be the ally in the fitness facility with someone that's obese and take on being well, helping them look at the whole person, because people like us being positive and empathetic instead of shaming them, right? So it's classic what you see on the TV show The Biggest Loser, right? We don't want to body shame like that. So I want you to consider all of their previous experiences without asking a lot of that. Realize, just accept that they probably have been through significant negative comments and ridiculed. Recognize that having obesity is a product of many, many problems and factors, some of which they may not have any control over. Explore all causes of presenting problems, not just weight. So water intake, how much sleep they're getting, pedometers. There's so many other things to quantify. Recognize that many of these patients have tried repeatedly to lose weight. I mean, most patients will tell you, they'll share with you diets and exercise plans and gyms that they've joined. Emphasize the importance of changing rather than weight. So the process, not the end goal. Acknowledge the difficulty, admit that it's hard for you of an ideal body. Perhaps, I don't know any of you on the other side of this camera, but it's just because it's easy for you to exercise is not going to make it easy for them to exercise. And that small losses can really improve their health. So I want you to now ask yourself these questions. Do I make assumptions based on weight regarding character, intelligence, professional success, health status, or lifestyle behaviors? It's a tough question to be honest about. Am I comfortable working around people of all shapes and sizes? Do I give appropriate feedback to encourage healthy behavior change? Am I sensitive to the needs and concerns of individuals with obesity? Do I treat the individual, or am I only treating the condition? So those are kind of raw, hard questions to ask. So what I want, again, this lecture was meant for physicians, but what I want you to take from it is focusing on health and wellness, on getting them to do good behaviors and less on the weight loss. Remove magazines and brochures from the waiting room that has got these social stigmas of, unrealistic body types. Make sure that we don't weigh people in a public area. We don't want to discuss how much somebody weighs where other people can hear. Have equipment that fits them. Right, a blood pressure cuff that's not big enough, don't even bother putting it on their arm. Scale that doesn't go over 300, don't even put them on it. Right, chairs in the waiting room that fit them. Assistive devices, right, don't exercise them on the floor. They're not going to be able to get on the floor. Maybe don't put them on a walking program. Walking might not be right for them right away either. So think about how, depending on the mobility, what are some of the assistive things can we be doing? Install grab walls, balance for them. Be sure to have seating. Again, I mentioned that they can accommodate. The bottom line here, and the references at the end of all of this, is really to open your eyes up to when we talk about in these discussion groups, our discussion forums that are so great. to really get to the nuts and bolts of what is obesity stigma.